Hello, everybody, and welcome to today's Teoxan webinar on infraorbital rejuvenation. Today, we are delighted to have Dr. Patrick Trevidick as a speaker. Dr. Patrick Trevidick is a plastic reconstructive and aesthetic surgeon based in Paris, France. He is the chairman of the Reconstructive and Plastic Surgery Department at the Sainte-Anne Hospital in Paris. He is a recognized plastic surgeon of the French Medical Council, and he's also a member of many international reconstructive and aesthetic societies. Dr. Trevidick has led and participated to many studies in aesthetic medicine and surgery. He's published several peer-reviewed scientific articles and presented them at international congresses. Dr. Trevidick has also contributed to several books on medicine and aesthetic surgery. He is the scientific director of the Expert to Expert group, sharing his knowledge and experience globally. Dr. Trevidick is a renowned lecturer in the aesthetic field, both in France and abroad, and we are delighted to have Dr. Trevidick presenting this webinar today. So Patrick, before I leave the screen to you, I just wanted to tell the participants that even though you are going to answer all the questions at the end of the webinar, please do ask the questions during the webinar in the Q&A tab of your Zoom screen, so that I do have time to read them before asking the questions to Patrick at the end of the meeting. Thank you very much, everybody. Have a great seminar, and thank you, Patrick.
Thank you, Fabienne, for your nice and warm introduction. So today, my purpose will be to share with you where we are with the infraorbital area. This is a medical vision because infraorbital area is an area where we have a lot of combined technique. And combined technique, why? It's because like in other places, like lower third, you can have, treatment with the medical vision and treatment with surgery or with toxins. So I will talk only about hyaluronic acid today, but you have to understand that in this area we'll have a different indication, and also I will show you where are the good indication for HA filler. If we are looking to some marketing study, we know that the tear trough is the second concern for young patients around 30, 34. And the third concern, if you take, another population around 60, 65. Why we have this? It's because tear trough, it's a big demand because the periorbital aging starts when you are around 30, raise until 60, and then stop. It means this is something that starts very early in your aging process. We'll see why. And then growing, and stop at 60, 65. And after, there is not a lot of modification. This is the opposite with the lower third, where the process of the aging process starts, after around 40, 45, and after increase until the end of your life. So it's a big differences when you are in the periorbital area and in the lower third. It is also, and we have only this, it's a 7 area corrected by aesthetic treatment. It means it's a second demand, but the 7th area corrected. And you see there is a balance between on one side, a big demand, and on the other side, it's an area where it's only the 7th one to be corrected. It's almost the same than for lips, where we have, a big demand, a big market, and on the other side, a lot of adverse event with lips injection. And why this paradox? It's because on the patient side, we have a fear of a bad outcome, as always, a fear of adverse events. And it's more, you know, because it's close to the eyes than because of the classical adverse event, bruising, swelling. And on the physician's side, it's sometimes because we don't have the right product for this indication, and also because a lot of people in this area, we know that it is a difficult and risky area. And this is the purpose of today, is to show you that if you follow some protocol, your outcome could be very good in this area, and your patient will be very, very satisfied. So this is why some patients, you know, don't want to be injected. Look at this, puffy eyes, some Tyndall effect, like these two patients, or too much, it looks like a swelling, it looks like a bump, or as you can see here also, a bump, a visible, you know, sausage of product under your eyes. And so you say to the patient, okay, it's because of the product, I have a swelling with this product. No, it's not because of the swelling. It's just because you put too much product. So this is what the risk in this area that is a little bit difficult. And you will have to understand this area before you will inject. So for that, we will follow, as usual, the Teoxane approach. The Teoxane approach, it's, as you remember, something I brought when I joined Teoxane, coming from expert to expert. And this is the three pillars of this Teoxane approach, with three letters, A, T, and P. A, it's the anatomy, because anatomy brings you the safety, but it's also A for assessment and A for aging process, because if you don't know what happens, you don't know how to correct it. Then you have the techniques. Techniques with an S, because, and moreover, for the tear trough, we don't have one technique. There is not one way to go to Rome. And the last point, and this is very rare for the company to put the product at the end, but the Teoxane approach is to put the product at the end, because it is when you assess the anatomy of the patient, the demand of the patient, you choose your technique, and last but not least, you choose your product. And you will see that with this area, it's very easy, because we will use only one product for this area. And don't forget the movement, even if in this area, the movements are not big enough. So we put products and we remove the S, because it's only one product. It's for us Redensity 2. So let's go and follow the path. Go to A with assessment, aging process, and anatomy. If you are looking to the patient assessment, you remember there is a demand around 30 and sometimes before. I want to remove my dark circle because I look tired, or around 50, I look tired, I look sad, what happens to my eyes? Look, I have not my beautiful eyes of my 20s, so this is a rejuvenation. But patients, they want always to keep their personality and also the natural look. Before we start, because this area is a little bit confusing, we will have to talk about the word we use, because if we don't use worldwide the same word, a lot of people will describe different techniques, different anatomy. So we will have first to focus on the word I will use, like the lip, for example. You have the white lip, the red lip, you have the wet red lip, dry red lip, Cupid's bow, or vermilion border. So you have a lot of names, and that's the same for the infraorbital area. So just to summarize, the first we use the tear trough word, it was flowers. That is a plastic surgeon from Honolulu, and he used this word in 1969, and the definition was, it was the inner depression of the lower eyelid. So this is the definition of the tear trough. It means that this is the lower eyelid depression. This is only that, the tear trough. So this is this. But you have a depression that is on the lateral side of the lower eyelid, and this is what we call the palpable malar groove. There is another depression under the tear trough, just here. This is the dark line, and this is the nasojugal groove. So look, palpable malar groove and nasojugal groove. And people also make a confusion because they say that the tear trough, it's exactly the mid-cheek fold or the mediojugal groove. It's totally different. It means I didn't tell you just because I love the word. It's just because this area here, the tear trough, it's behind an anatomical feature. Your mid-cheek groove, it's also because there is the buccomandibular ligaments. The nasojugal groove is because behind you have, you know, something here that is the angular artery. And if you are going to the palpable malar groove, it's just because you lose your fat. So you see, behind the word, you have an anatomical explanation. And so the treatment will not be the same, because why you have that, it's totally different. And so, for example, your tear trough, it's not this line here on my face. It's a combination between two anatomical features. First, at the upper part, you have the tear trough, and following the tear trough here, you have the mid-cheek fold. But the tear trough is not the mid-cheek fold, and the mid-cheek fold is not the tear trough. And it's not only word, but we have to be clear on the word that we will use, because it's totally different. So let's take this example. It was the financial minister in France. He has a big tear trough, and also he has a mid-cheek groove. So you see, these two lines are almost on the same line, but they are totally different. This is the word. Now we are looking to anatomy, and we will check what happens when you do a dissection in this area. So you remember, infraorbital area, it's the tear trough and the palpable malar groove. Why we have a tear trough? Look at this picture. This is the orbicularis oculi muscle. That is a flat disc above your orbit. This flat disc above your orbit sticks to the orbit where? In the tear trough. So the tear trough is exactly the location where you have the bone origin of your orbicularis oculi muscle. Look at this here. You have the tear trough here with your muscle sticks to the bone. So because it sticks to the bone, it creates a depression. why we have a palpable malar groove is totally different. It's not because you have your muscles that stick here. It's just because your superficial fat, that is the infraorbital fat compartment here, disappear and create a bump that is the palpable malar groove. So you see there is a big difference between tear trough with a ligament and a muscle that sticks on the bone and the infraorbital area. Look here, there is a variation of fat. When you are young, a lot of fat erases everything. When you are old, you lose your fat and you have a skeletization of your orbit. But moreover, your infraorbital orbit here is going backwards. It means that if your muscle sticks to the tear trough and the bone is going backwards, the depression in the tear trough will increase. This will not change anything in the palpable malar groove. And you have the variation in skin. You know that the skin of the eyelid is the thinnest of our body, and you have a lot of wrinkles that you have during your aging process. And at the same time, the intraorbital fat increase, and so there is a bump over the tear trough that is the bump of your palpable bag. So it creates mountains above a depression that is the exact location of the dark circle. It's for that it's becoming darker and darker with the time. So look at this dissection. You have everything on. Palpable bags, orbicularis oculi, where you have the tear trough and palpable malar groove, and infraorbital superficial fat compartments. So if you erase the palpable bags and open the muscle, I erase the palpable bags, you see here the muscle here inside, and I hold here my orbicularis oculi, and you will see that to lift this muscle, I need to open because it's where my muscle sticks to the bone. So my tear trough is here, and my tear trough finish where the souffle will start. So let me open the orbicularis oculi muscle, and you will see that if I open it, and you see the nasojugal groove is just under. I open the muscle, I lift the muscle, and you see here the souffle. So the souffle starts when the tear trough finish, or the souffle finish where the tear trough starts. So where is the anatomical danger? The only anatomical danger is this artery here. This is the terminal branches of the fascial artery, and the name is angular artery. If I do a dissection, you see here a dissection where you have the tear trough, and just under and medial, you see the vascular network. So do we have any danger in the real tear trough? It means, you remember the inner depression where you have the white line? No, we have no danger. It means you can do an injection in the real tear trough, not in the nasojugal groove. Because the nasojugal groove that is just the depression under the tear trough, it's the exact location of the angular artery. Look at this movie. You have the angular artery with my needle inside, and you have my cannula that is just at the level of the tear trough. So the tear trough has no danger. The artery, either the nerve, you have no danger in this area. As you can see here, the angular artery is superficial above the orbicularis oculi and is in the nasojugal groove, not in the tear trough. And after it's going along the side of the nose, perforates the corrugator supercilii, And the nerve, the foramen of the infraorbitalis nerve is below your injection. So you have in the real tear trough and in the palpable malar groove, you have no danger. You have no big arteries. And even the infraorbital artery coming from the infraorbital pedicles, one branches is going up, but is very superficial. Branches are going to the zygoma, but mainly the branches are going to the nose. So for the tear trough, this infraorbital artery is not a danger. Whatever the tool you will use, needle or cannula. So why so many people use a cannula to do their injection in the tear trough like me, if you ask me this question? But Patrick, there is no danger if I use a needle. I will say no, there is no danger. So why do you use, Patrick, a cannula? It's not for safety reason. It's because in this area, we have a lot of swelling and I want to avoid the swelling. And I know that my cannula, we don't have time to compare needle and cannula, but we know that with the cannula, because of the blunt tip and the lateral hole, you will have a delicate undermining, and you will have also a flow of product without the turbulence that you get at the end of the needle. So it's for that I use a cannula, for the swelling, not for safety reason. This is very important to understand. So perhaps, Fabienne, we will do a poll question on this anatomy before we are going to T, that is the techniques.
Yes, Patrick, the poll is on.
So now you can vote and we will let you 45 seconds to vote. We are more than 2,100 so attendees, so it's a very good numbers like we did before. And just to remember you that we have our next meeting, our next webinar will be next week on Tuesday on nodule formation. So did you have 45 seconds to vote? So what is the definition of the tear trough? Why we have a tear trough? So finishes. Perhaps, Fabienne, we can share. So as you can see here, what is the definition of the tear trough? It's the depression at the inner part of the lower eyelid. Yes, you're right. 70% are right. This line is going from the medial canthus to the mid-cheek to the upper part of the mid-cheek, not the lower part. The lower part is the mid-cheek fold. That is not the same than the tear trough. The mid-cheek fold is because you have a ligaments here. Why we have a tear trough? It's all the answers are good, you're right. It's because of the bone origin of the orbicularis oculi, also because the absence of fat at this level, and because of the tear trough ligaments. The tear trough ligaments, there is just one publication done by Mendelssohn, the team, the Australian team of anatomy. It's a very good article, but only this team finds this. The previous team would study, the tear trough, didn't find any ligaments. The SUV finish, where the SUV finishes, yes, a little bit under, but it's mainly at the lateral border, as you are right. And the palpable malar groove is because of the infraorbital fat compartments. The zygomatic ligaments, it's much, much lower. What does it mean? Look at me. My my palpable malar groove is just here, and my zygomatic ligaments, if you want to have a view of the zygomatic ligaments, look at the people who have, you know, malar mons, a swelling in the malar area, and the lower limits, the lower border of these malar mons is the zygomatic ligaments. So it's much, much lower than your palpable malar groove. So let's go. I will have to do a new. Okay, the techniques. You see, I put an S because there is not one technique to do it. And I will show you what is in all the meeting, the technique that the highest number of speakers, of people use for the tear trough injection. And we did a poll with Teoxan recently regarding the tear trough injection, and mostly 90% of the answers of this poll follow this guideline. So I will share with you these guidelines, and I will tell you after also, because there is no one technique, what you can use and how you can deal with this area. So if I'm going to this technique, first, the position of the patient. If you start, please put your patient in a sitting position. Very important. I will tell you after why. Then you do a drawing. Also very important to do a drawing to mark the real tear trough. And you see here, I mark the tear trough here, and I go on the same line because here will be my entrance point. I do a disinfection and I calculate, because I will use a cannula, the length of the cannula to be sure that from my entrance point to the highest peak of my tear trough, my cannula will be long enough to reach this highest peak. With my needle here, very important, my needle gives me the depth and the direction of my cannula. If you just open the dermis, it will not be enough because the blunt tip cannula will not succeed to cross all the layers. The needle can do it, the cannula can't do it. So I'm going on the bone, look on the right side, you will see where I am. I'm in the souff. You see here, the yellow here, it's the souff, the deep fat compartment. And I follow the red line. So my cannula is sliding on the bone and going up to the top of the bone. Some tip and tricks. If when you do that, it's not an easy process, stop, don't go forwards, or your patient will feel pain and you will not be in a very good situation. So in this case, if you feel some resistance, just push a little drop of products. Do an anterograde injection and not a retrograde one. With these little drops of injection, you will just put some products, that is the HA plus Lido, and after this will smooth your process. Look at the differences between one side is done with 0.3 ml and the other side is not done. Look at the depression, look at the darkness. I will show you a lot of examples. So remember, my needle gives me the depth and the direction. My cannula 25 gauge between 40 and 50 millimeters, depending on the length of my tear trough, and injection, anterograde or retrograde injection, depending if you feel a resistance. Another case here with the soft fill cannula and an easy guide, going deep on the bone, sliding on the bone, going until the peak, the highest peak of my tear trough here, the darker one. I use redensity 2 only. I will go to the products after. And what is the secret? Don't try to remove everything. Don't try to remove all the depression. It's better to inject less than too much. Because if you inject less, it's possible to do a touch-up. If you inject too much, we'll see that after. It lasts a long, long time, and you will have to use hyaluronidase. So here you see, I rotate my cannula, orientate my cannula in the lateral south, deep on the bone, to the palpable malar groove, and going just here, where you have the skeletization, and I put an average per side of 0.1 to 0.2 ml of products. And even if you have any bump, you can just mold it. Don't do a massage here. If you do a massage, your product is just on the bone, and above you have just the skin and the muscle. So if you do a massage, your products will be squeezed because it's a very malleable product, and the products will go up and down regarding the margin orbit. And so it will not decrease the tear trough if you do a strong massage. It will increase your tear trough. Sometimes when there is a strong ligaments, a strong adhesion of the muscle here, you can do a decision with your cannula, or you can do like my friend Philippe Barros. You just try to lift the tip of your cannula just to make, you know, a dead space to inject, just to release the ligament, and just also to release the adhesion of your tear trough area. Here you see where I am. I'm here on the bone, under the muscle. I'm not following the aging process because you remember why we have the palpable malar groove. It's because we lose, you know, our superficial fat. And I didn't put my products in blue here. This is a cadaver dissection. I didn't put my product above in the fat to correct the decrease of the fat in the area of the palpable malar groove, but I put my products under the orbicularis oculi that you see here, holding by my pinch, but I put it deep. So I'm not logical, and I assume that I'm not logical. My friends in APAC, in Asia, because they have thick skin, some of them use superficial injection. But because I'm working with Teoxan, and because the recommendation of this product is to put this product deep, I can't tell you today with the Teoxan webinar that you put your product superficial. But regarding the aging process, it would be more logical to do a deep injection here in the tear trough and a superficial injection in the palpable malar groove. I don't know if I am clear enough with you, but always when we are looking to the aging process, we want to follow what happens during the aging process to correct. And for the infraorbital area, you see here, I put the product deep above the bone, in the bone origin of the orbicularis oculi muscle. This is the periosteum. This is a fat, intraorbital fat. Here's the palpable bags. But you see here, I put the product deep, and normally it's this fat would disappear here, the superficial fat. So let's summarize the technique. This is the technique. Entrance point on the left, your needle gives you the depth and the direction. Then introduction of the cannula, 25 gauge, sliding on the bone. If I feel a resistance, I inject a small drop of HA. You remember that HA, it's a gel. This gel will create around your cannula some gliding space. And so it will ease. So when you feel a resistance with your cannula, stop it. Your patient will tell you, hey, stop, I feel some pain. And why you have this resistance, it's often because you are not deep enough. It's often because you are above the souffle or in the superficial souffle. And if you want to go deeper, you will have to cross the layers. So it's for that sometimes you have a resistance when you do this. But normally, if at the beginning you put the tip of your cannula on the bone, it will slide with no resistance. So this is the second step. Look, this is my needle going deep on the bone. This is my superficial fat here. The name is infraorbital fat compartments. This is my orbicularis oculi, and my tear trough is just here. My nasojugal groove is here. And you see here, what is that? This is the vascular network under the tear trough in the nasojugal groove. So I push my cannula. It's a very easy process. And you see here on this drawing, the different depth of my cannula with here, the different layers regarding the anatomy of each part of my infraorbital area. And this is my cannula, 25 gauge cannula, and my blue HA that you can see a little bit in the muscular fibers, because I tell you that I put my cannula deep just on the bone. But there is no dead space between orbicularis oculi here and my bone here, because my orbicularis oculi bone origin, it's just in the tear trough. So my cannula slide not between the bone and the orbicularis oculi. My cannula is sliding in the bone origin of my orbicularis oculi. So here, why you see a little bit the blue HA we use in our cadaver lab studies, it's because you see the blue just inside the muscle. If you are in the nasojugal groove, you can be under the muscle. So you see the difference of the anatomy between the real tear trough and the nasojugal groove here. So you see how you do your injection, your retrograde injection. And here you see the exact location of your cannula. So if I summarize, you see here the souffle. My pinch hold my orbicularis oculi, that is a floating disc above the orbit. But in one place here, you see my orbicularis oculi muscle sticks to the bone. Not here, but just here. And my cannula is going up, 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 up to the peak here of the tear trough, the darker area of my tear trough. So my cannula, you see, I hold my orbicularis oculi, and my cannula will be just here until the peak, and this is the products here. This is, as you can see here, my products deep. You see it because the muscle is very thin. It's not because I'm above the muscle. It's because the product, the redensity 2 diffuse across the muscle. And what you see here, this is the superficial artery coming from the infraorbital artery. And what is this? This is the fascial artery going up, and this artery will be above the muscle if this artery finish with the angular artery, because you know you have a lot of anatomical variation. So we see the technique, but we didn't see the indication. And this is the patient assessment, very, very important. You look to your patient face, but you forget the profile. And for the tear trough, profile or 3/4 are very important. This is what we call the negative vector. This is a good indication for HA injection in the tear trough. What does it mean? Negative vector is a publication of one of my friends, Jakes, an oculoplastic surgeon of New York, that creating this for the treatment of the palpable bags in the past. And he said that the negative vector is not a good indication to remove the fat pad because you will increase the hollowness of your lower eyelid. What is the vector? What is the palpal vector? It's a line, it's a virtual line that you draw from the line, the border, the upper border of your eyelid to the border of your orbit. If you draw this line, and if your orbit is backwards, as you see on my patients here, you see that my eyelashes here are at the front and my tear trough is at the back. So it's a very good indication to feel this area here. I surround. So this is a good indication for tear trough injection. And you see here some negative vectors, some good indication to treat these patients. Good indication, but as you can see on these patients, please don't feel all the depression. This is a little trick. If you want to erase all the palpable bags here or here, you will put too much product. It will make a puffy eyes. And if you put a puffy eyes here, it's not a puffy eyes, it's a puffy eyelids. If you put a puffy eyelids, your patient will not be satisfied, even if you treat the demand, because if you put puffy eyelids, the eyes will look smaller. Because if you surround your eyes with volume, the eye, the globe, will look smaller. And they don't like that. So in this case, here or here, I will just feel a little bit, and I will not feel until I reach the level of my palpable bags or the level of my nasojugal fold. So here I will feel less, just to decrease this depression, but not to feel it until I find the level of the eyelid. I'm not sure it's 100% clear, but don't put too much. Do a test on you if you have a tear trough. Take a redensity 2 syringe and put in your tear trough the amount of products above your skin you need to remove the depression. And you will be surprised as me, because I have a tear trough. And if you feel all my depression, you will see that there is only 0.3 ml of products you use. So it's always less than a lot of products. This is the bad indication. What is the bad indication? The bad indication is what we call the neutral vector or the positive vector. And it's also when you have a skin laxity. Be careful with the skin laxity. I will show you this movie here on the right side, where I do, look, I release, and you see how long it takes for the globe. It's called the snap test. If the eyelid, when you pull on the eyelid and you release the eyelid, if the eyelids, you know, takes more than 3 seconds to go back to the globe, then you will have, you know, a skin laxity. So neutral or positive vector or eyelid laxity with a snap test at more than 3 seconds, it's not a very good indication for your HA filler injection. Look at this publication, very interesting, 2018, very nice publication done by one of my friends, Val Lambros and Glazer. They are plastic surgeons, and they look to the relationship between the mid-face volume deficit and your tear trough and nasolabial fold. And what they found is that there is a very big relation between your cheekbone, your nasolabial fold, and your tear trough. It means if you correct with the multi-layering technique your cheek area, you will have a partial correction of your tear trough and your nasolabial fold. So there is a relation between these 3 areas of the face. Don't forget that. And if you have an order, start with the multi-layering technique and with Ultra Deep and RHA4, and finish with the redensity 2 for the inner part of the tear trough. Here, it's for me to summarize what I said about the technique. Look, you have a patient with a tear trough on the left side, and where is the cannula and how you inject and where you inject your products. And for the palpable malar groove on the right, you have also the same view of the product above the bone. Even if it's not logical, I put my products above the bone because my products is very soft, very malleable. If you use, for example, classical products like Global Action or other products, competitors here, the risk to have a bump in the palpable malar groove is higher than in the tear trough. So this is to summarize what you can do in your periorbital area with redensity 2. That is for me the product I use because I have this product, but I will explain to you after what you can use for this area if you don't have redensity 2 in your country. So perhaps Fabienne, yes, we have the poll. So it's about the technique. And may you answer, you have 45 seconds to answer. I will summarize. Anatomy, it's clear. Tear trough, palpable malar groove. One main danger, the angular arteries that is normally far away from the palpable malar groove, that is below or medial to the tear trough. So you can use, if you want, a needle. You can use a needle to do your tear trough. You can use a needle to do your palpable malar groove because there is no arteries there. But the needle, the length of the needle is 13 millimeters. The length of a tear trough, it's around 40 millimeters. What does it mean? It means that if you want to do a tear trough correction with your needle, you will have to go through the skin 2 or 3 times to correct all the tear trough. So you will have 3 times more risk to get a bruising, to get a swelling, to get an hematoma. And we know that the hematoma lasts a long time in this area. When you do something and you have a shock here, when you hurt yourself, you know that the hematoma around the eyes lasts a long time. So it's for that. We can stop the poll and share the outcome. So as you can see, could we use a needle to correct the nasojugal groove? Yes. But if you use here, under your tear trough, in my nasojugal groove, and I see you with a needle, I will tell you, please go to the bone. If you do it superficially, you have the maximum risk to touch my angular artery. Is it safe to use a needle to correct the tear trough? Yes, it's safe. If you are really deep on the bone, bevel down, sliding on the bone. Remember, when you are on the bone, this is the bone, this is my needle here. If I'm going like this, perpendicular to the bone, and stay like this, because of the length of the bevel, a part of the bevel will be more superficial than the end of my bevel. So the way when you touch your bone like this, to be sure that all the bevel will be on the periosteal plane, is to touch the bone bevel down and to slide on the bone. This is the only way when you do your technique to be on the bone, to feel the bone. What is the recommendation for the cannula? My recommendation is 25. Yes. 30, 27, please don't use no more this cannula. We have more and more articles published, prove that these 2 cannulas could not avoid the vascular compromise. We use the tear trough, the cannula, well, yes, it's just because of less bruising. It's not because of the vascular compromise, because you know that in the tear trough, it's not possible to get a vascular compromise. So I will go on and I will stop this and I will do oh, sorry. When I stop, it's always the same. I go to the products. So you remember ATP. A, anatomy, assessment. T, the techniques, needle or cannula. Products. The infraorbital fighter, it's redensity 2. It's redensity 2. It's a product dedicated to the periorbital area. Why? It's because this product is very specific. It contains a mix of HA with a high molecular weight, with a mix of cross-link and non-cross-link product, 70%, 30%. This is the rate of cross-link, non-cross-link. This is also a product that contains a cocktail. And this cocktail, inside you have 8 amino acids, 3 antioxidants, 2 minerals, and vitamin B6. And you have also, as usual, the lidocaine. So this is a very specific product. This is the only one in the market where you have on one side something that improves the depression, and on the other side, you have a product that can improve the quality of the skin. So it will create, you know, it's a product where you have 14 milligrams per ml with a low hygroscopic physical property, very, very important. This product spread because it's very malleable, and so your modification degree is very low because it's a classical product. You remember when we talk about the products, normally the classical products in the market, the modification degree is between 5 and 15. It means it is the BDDE crosslink. And the RHA products is between, so the new scale of products is between 2 and 5. So these products have a very good modification degree. And this is the indication here. As you can see, it's a periorbital. It's dedicated for that. So when you think tear trough, you think redensity 2. When you think redensity 2, you think tear trough. And small volume, deep injection, this is the IFU, and you can inject as you want. So you have 2 properties. On one side, the property of a mix of, and on the other side, the complementary action of the nutrition cocktails you have inside your syringe. So if you are going to the property with the viscoelastic property, rheological property, we know, as I told you, that there is a low hygroscopic property, so not a lot of swelling. And you have also a very light consistency because of the mix of the 2 products. So it's not a product that can create a bump, that can create also a Tyndall effect. Because Tyndall effect is because it's a high cohesive product, like Restylane, for example. At the beginning, when we did tear trough injection with Restylane, we have a huge number of Tyndall effect. It's because it's a biphasic product, so a strong product, and sometimes it was also because we injected too superficially. Tyndall effect is just because of the light. It's the reflection of the light in the HA. So because this product is deep, and because this product has all these properties, you have no Tyndall effect in our clinical studies. So this improves, you know, and ease the injection. And it's a very forgiving product. But don't do a strong massage, because if you do a strong massage, you will create more depression. Here, the specific rheological property, look at global action. If you press on it, you see that theosial redensity 2 doesn't maintain, you know, if you push a lot, the bump. And it's the opposite for global action. We did a multicentric study starting in 2011, finished in 2013, and you see what happens. We have patients, it was mainly 86%, it was women, and in this study, we enrolled, you know, 33 practitioners. And it was, we used at this time the 27 gauge. Average volume injection, 0.4 ml by size, so it's not a lot. So we put these products deep, and we use multi-puncture technique. And so this is the improvement, so what we call the global aesthetic improvement scale, with the physician opinion and the patient opinion. So a lot of exceptional improvement or very improved, but very few patients with unaltered patients. We have also, remember, we have the nutrition cocktails with, you remember what is inside? You have a product with 3 antioxidants, you have vitamin, and you have amino acid inside. So you have with this a restructuring complex, an antioxidant protection, and a skin hydration. And we did some study, and at this time, if it was control, it was nothing, because we didn't have any competitors. So you can tell me, yes, but it's perhaps because of the HA, because we know that HA give, you know, all these properties. You know that HA stimulate the collagen. You know that HA stimulates the elastin. It's not HA by himself. It's the degradation of HA that stimulates CD44 that will increase the rate of collagen and elastin fibers. So perhaps we didn't do a double-blind study with, on one side, nothing, on the other side, only HA, and on the side, HA plus the nutrition cocktail. But look at the difference. You have a redensification of the papillary dermis, a redensification of the structure of the glycosaminoglycan. And here you see the increase of the collagen and the fibrin with this nutrition cocktail. And here, the glycosaminoglycan, more than 14 times more with this vitamin cocktail regarding the control. And here it's the same study, you remember, where we asked the patient and the doctors, are you okay if you use a global aesthetic improvement of the skin? What do you think? And you see that a lot thinks it's very much improved or improved. So a very good action on the skin quality. And in this area, you have to improve the skin quality because you remember the aging process. And with the aging process, we have a lot of thinnest, you know, very thin skin at this level. And because of the aging process, it's becoming thinner. So you have to improve the skin aspect in this area. Poll question, the third and the last one, before we will see some clinical cases. And at the end, in 10 minutes, I will also answer to the main question. I couldn't answer to all the question because at this time we are more than 2,200 and we have more than 83 questions at this moment, but I will answer to all of you individually to all these questions. We will choose with Fabienne some of them. So if we stop the poll on the products and we see what happens, Redensity 2 is a non-crosslink product. No, it's not a non-crosslink only. It's a mix of non-crosslink and crosslink. Redensity 2 contains arnica. No, you are right, it's no. IFU, so it means what you have in the leaflet that is inside the box where you get your Redensity 2. This is the IFU. This is what is the recommendation of Teoxane, how to use the product, because this is the way we use the products during the clinical studies we do in our clinical research center. So it's to do an injection deep and not superficial. You're right, so you are very good. I don't have Redensity 2 in my country. Can I use RHA 4, 3, or 1? Yes, 1. You're right, because RHA 1, it's almost the same than Redensity 2 because it's a mix of crosslink and non-crosslink, but the average 70-30%, it's a little bit different, that's all. But you don't have inside the nutrition cocktail that you get in Redensity 2. So it's for that you will have not this little plus inside your syringe, but it will be, you know, the same for you than with your redensity 2. So if you don't have in your country redensity 2, then you will use, in this case, RHA1. That is a good product for that. So RHA1 here, you remember it's a 15 milligram HA, like redensity 2, with a very high stretch. So it's a very forgiving product, same, very good physical and rheological property. And you see, this is something where you compare both and you have less modification degree than redensity 2. Quantity, use more than one syringe for both sides. This is my advice. Redo it, do a touch-up, but don't use more than one syringe. How long it lasts? A long, long time. This publication, 2012, with Restylane product, 5 years after, you have still product. That's the same in our clinical study. When you do ultrasound study or MRI study, after injection of redensity 2, we found the product after 3-4 years. It's good, because like this, you will, your patient will be very satisfied on the long term. But it's bad if you do any adverse event, overcorrection, misplacement. You will need to use hyaluronidase and don't wait the product disappear spontaneously. Clinical case. Look, I will not show you 100 cases I did, because I did thousands of patients for tear trough areas. So this is a patient where I put redensity 2 in the tear trough, but also a little bit above here, just to correct my palpable bags. Another case here where I put only redensity 2 in the tear trough. Look at the, did I change the color of the skin? No, but the patient feel that you change the color. Why? If you put a dark circle in a depression, with the shadow, it will look darker. If you put your dark circle above, the light will reflect and look less dark. This is the same case here. Look at the darkness. The darkness is much, much less. Here, another darkness, another depression. Look, I did to this patient, you remember the relation between mid-cheek and tear trough. For this patient, I did a multi-layering technique here, and I did redensity 2 in the tear trough. You see the difference? A good mid-cheek, a good tear trough. Another case. Here I did only one syringe of RHA4 plus redensity 2. Another case, I did only RHA4 in the mid-cheek superficially, and I did here redensity 2 in the palpable malar groove and in the tear trough. I use one syringe in this case. Here I use more than one syringe. Why? You see how deep was the depression. This depression is what I call the V depression. It's between the tear trough on the medial side and the palpable malar groove on the lateral side. And in this case, I put more than one syringe for both sides. So it means I use 1.5 ml of products. Here it's another case. Look at the depression, look at the color. Same here. Look at the depression, look at the color. It's limit the indication here because you see there is a skin laxity. And so it's not a good case. So to summarize before the question with Fabienne, anatomy, no danger in the tear trough. Techniques, for me, deep, cannula, not too much. And the product, if you can have these products, 100% it's redensity 2. If you don't have, take RHA1. Fabienne, we have now 5 minutes, 10 minutes with the 2,000 attendees still there to have the question.
Hi, Patrick. Yes, and thanks everybody, the 2,000 participants for attending this great webinar. Thanks, Patrick. So we actually have quite a few questions on the subject of the depth of injection. So can you explain basically why you have to inject deep and what happens if you inject superficially in the tear trough?
Why I have to inject deep? It's because when you do your injection, I will go back to the anatomy. I will not inject superficially first, not because of your anatomy. If you want, you can inject superficial. But remember, in the tear trough area, if you do a dissection in this area, I will go back to my anatomical view here. Look, you see very well on this dissection that you have a tear trough and a dark circle, first because of the color of the skin, but also because you have no fat here. So it means that if you inject superficially, and if you put a product, whatever the product that is a gel, the risk, if the skin is very thin, is to see the product, is to have bumps, because it's very difficult to be very regular all the time, even with the cannula. So it's for that, because there is not a lot of layer there. You have skin in the tear trough, no fat, almost no fat, muscle and bone. So if you make a measurement of the thickness of this area, it's a very thin area. And so I prefer to avoid the bump, and it's for that I'm deep. But I know that, for example, in Asia, a lot of my colleagues inject superficially because the skin in Asia is very thick. So they're injecting there. This is the first point. And the second point is because if we are going to the products redensity 2 has been a study by Teoxane with deep injection. So we can't advise our consumers to do a superficial injection. But I know it works. So it's a question of techniques and of patience.
Thanks a lot, Patrick. We actually have a question that is a bit in line with what you were saying about the thickness of the skin. So for patients who have quite thin skin, it's important also to treat the skin itself. So what are your recommendations in terms of treatment for the skin quality in this area?
If you go to this slide, look at this slide. I told you that I did a deep injection. But as you can see, if we do an histologic study where I put my pointer here, you will see that the products, even if you inject deep, diffuse in the muscular fibers and will arrive to the level of the skin. So my redensity 2 with my two products together, it means on one side, the volumizer, I don't call it the volumizer, but it's to create, to treat the depression. So this is the HA, and my nutrition cocktail, both together will improve the skin quality. So when you do an injection of HA somewhere, it diffuses a little bit. It moves a little bit upwards and it reaches the skin. So I'm not a dermatologist, but often my injection of Redensity 2 improve not only the depression, but improve also the skin quality. And after I do, if there is wrinkles and if there is something to improve, I do a peeling or I do a laser to the skin of my eyelids.
Great, thank you so much, Patrick. We actually have quite a few questions on Tyndall effect. Have you ever seen some delayed Tyndall effect, like several months after the injections? And what are your tips and advices to avoid that?
There is two things. Tyndall effect, the real Tyndall effect, in my point of view, is very rare. What we see sometimes, and I see that because I receive a lot of adverse event pictures coming worldwide, because I'm responsible for the adverse event worldwide for Teoxane, but I see also a lot of adverse event because I have a center in Paris that receive the adverse event from Paris. People send me some patient or some picture and say, look, Patrick, I have a Tyndall effect. And when you look at the patient before and after the injection, it's not really the Tyndall effect. It's not blue, it's dark. And it's because you make the dark circle more superficial. And so sometimes the patient come back and say, look, I have no more depression, but you see, I have still the dark circle. You can't remove the dark circle because the dark circle is the color of the skin. So you will not remove the dark circle. So a lot of people say, oh, this is a Tyndall effect. No, it's a dark circle that remains the same, but is more superficial. And because you have no more depression, you see only what remains there, it's the dark circle. The Tyndall effect, it's really a blue aspect of the product. And it can be delayed because at the beginning, you have the swelling. And the swelling make you know the light can't cross the swelling and go to the HA and reflect the light in blue. So the swelling erases the Tyndall effect. Let me go back in my presentation to show you what is a real Tyndall effect. A real Tyndall effect, if you look to my patient at the beginning, this one here, look, it's blue. You see, it's not the dark circle here. It's really blue. And the blue, it's because the light reflects through the very thin skin. And remember, eyelid, it's one of the thinnest skin of your body. So this is why if you put products very superficial under the skin, the risk of Tyndall effect exists. And moreover, if you use a biphasic product, because of the physical property of the light and the physical property of the product.
Great, thank you so much, Patrick. Actually, we have a question related to your comments on the longevity of the product. In average, what would be the time lapse you would recommend in between two treatments for a patient, given that Redensity 2 has a great longevity?
In all our clinical study, we recommend to do a touch-up after 1 year, like the other product, RHA, classical scale, whatever the location. But for Redensity 2, we started to use this product in 2011. So it means we have 10 years, almost 10 years of experience with this product. And we know really well, not because only of our patient, but about the patient who are coming from other practitioners, that when you do an injection there, it lasts 2 years, 3 years, 4 years sometimes. So my recommendation is not to say to the patient, hey, please come back to see what, no, it's to follow your patient, because the aging process, perhaps you will have to do a nasolabial fold, fine lines, a mid-cheek. So when you follow your patient, I follow my patient and I say, oh, perhaps we will redo the tear trough that we did 2 years ago. So this is a way, when you have a long-lasting effect, to follow your patient and to say, okay, we'll do other things. And when we'll see that it is time to do it again, we'll do it again.
Great, thanks, Patrick. So we have another interesting question. So do you think that treating the mid-face could help treat the tear trough? And if so, then in terms of your treatment plan, when would you recommend treating the mid-face and then the tear trough, basically?
When you are looking to a patient, when you look to the periorbital area, you have to assess also the area that are around your periorbital area. So you will check everything. And we know from the clinical study that there is a relationship between the tear trough and the mid-cheek deficiency. It means the mid-cheek deficiency will increase the aspect of the tear trough. So when you check a patient and you see the tear trough and you see that there is a lack of volume here, my recommendation will be to do it if you want at the same stage or in 2 steps, depending your relationship with your patient. Sometimes they trust in you and they say, do what is the best. In this case, I do multi-layering technique, and in the same times I do my tear trough injection. Or sometimes they prefer to do tear trough and they will come back for the mid-cheek. Or sometimes they are coming for the mid-cheek and they will, at the end, in the second step, do the tear trough injection. So it depends on your relationship with your patient. It depends what you discuss with your patient. Sometimes you can convince them that it's better to do the mid-cheek first and tear trough after, but sometimes you can't because they are coming for a specific reason. And in this case, I don't try to convince them because I lost a lot of time to explain why they have to do it. And when they come back, they say, hey, perhaps you did my cheek, but I've still my tear trough. So it's always a question of to convince a patient, and it depends more on you than me.
Thanks, Patrick. I think we just have a last question to finish. Could you just remind the participants about your tips and advice for the entry points for the tear trough with both cannula and needle, and what are basically the anatomical landmarks that you use? Okay.
So first, when you do an injection in the tear trough, what is very important is to do your drawing, because after, with some swelling sometimes, it's very important to locate where we need to be, as you can see here on my drawing, my cannula. So I will follow this. And because you have a tear trough depression, you can see not the cannula, but you can feel it because it's a 25 gauge. So if you are a little bit lost, if you don't know where is the tip of your cannula, feel it with your fingers. Do your injection in a sitting position. Why? Because if you do in a lying position, your fat of your nasojugal groove will come over your tear trough. And if you do an injection a little bit too superficial, your injection of HA will be in your nasojugal fat. And so when your patient will standing up, your HA will move down. So in this case, I prefer you to be in a sitting position, because if you are a little bit too superficial, it's a fixed point, the tear trough, and so your product will remain at the same place. So here, I will do my entrance point. Normally, if I do only the tear trough, I do my entrance point on the lateral side. If I have to correct my tear trough and my palpable malar groove, I draw the two lines with my drawing of my tear trough first line and my palpable malar groove, my second line, and where at the cross of the two lines, I put my entrance point.
Great, thank you so much, Patrick, for this great webinar and for answering all these questions. Thanks to the 2,000 participants that were here today, and let's see everybody at the next webinar. Thank you very much, Patrick. Have a good day. Stay safe.
Bye-bye. See you on Tuesday. Bye-bye.
Bye-bye.